At the International MPN Congress, I'll be discussing anticoagulation management in the myeloproliferative neoplasms. This has been a prevalent complication of individuals who have myeloproliferative neoplasms. And in order to understand the best approach to prevention of the thrombotic complications of the myeloproliferative neoplasms, it's important to understand not only the epidemiology of thrombosis in these disorders, but also to understand the bleeding complications that are associated with them as well. So that prior to the discussion of how I would use anticoagulant management, I would like to go over in my talk the epidemiology of the thrombotic incidence in the various myeloproliferative neoplasms, as well as to understand whether there are any predictability scoring systems that we could use for thrombosis and also for hemorrhage in the myeloproliferative neoplasms. And then to talk about potential biomarkers, the effect of JAK2 kinase mutations, and then to talk about some of the options that we have for anticoagulation, and then move on to some data gaps, and finally to discuss how anticoagulation has been influenced by COVID-19 infections which occur in individuals with myeloproliferative neoplasms. So first of all, in the epidemiology of thrombotic complications in MPNs, it's well accepted now that the arterial and venous thrombotic complications are increased in MPN patients of all ages. It's interesting that most of the thrombotic complications occur very early after the diagnosis or a presentation of the myeloproliferative neoplasm. Most of the thrombotic complications occur in polycythemia and essential thrombocythemia. However, thrombotic complications are also present in primary myelofibrosis, albeit in myelofibrosis patients, we often think of increased bleeding complications rather than thrombotic complications because of the platelet disorders and quantitative platelet abnormalities in myelofibrosis. Nevertheless, thrombotic complications and deaths occur in all of the myeloproliferative neoplasms, and it's important for us to be able to determine which subcohorts of each one of these myeloproliferative neoplasms would be at highest risk for thrombosis so that we can more astutely introduce the concepts of anticoagulation. Because all of these myeloproliferative malignancies also have bleeding tendencies. So I think that one of the interesting things about the myeloproliferative neoplasms is the fact that JAK2 burden has been shown to be quite relevant and well associated with the onset of thrombotic complications. It's also been associated with death. So as we go through the myeloproliferative neoplasms, perhaps one of the more interesting issues is why is it that the myeloproliferative neoplasms are associated with higher incidence than the general population of splenic thrombosis and cerebral venous thrombosis. It's not really clear how this occurs, but it's probably related to the fact that these various venous systems, which are highly susceptible to thrombotic complications, are probably low oxygenated states and maybe perhaps are associated with more stasis and therefore sets individuals up for more thrombotic complications in these areas. We don't really understand yet whether or not individuals' underlying comorbidities might also be contributing, so that smoking, the use of oral contraceptives in women, the inheritance of the thrombophilic gene mutations like factor V Leiden or the prothrombin gene mutation, paroxysmal nocturnal hemoglobinuria clones. All of these are diseases which are associated with a higher incidence of splenic and cerebral vascular venous thromboses as well. So we really don't know yet how to put all of these together, but I think the issue is that we have to deal with their occurrence. And once we begin anticoagulation, we also have to realize that particularly in splenic thrombosis, there's a high incidence of bleeding. And so when we initiate our strategies for anticoagulation, what options do we have? Well, we have the unfractionated heparin, the low molecular weight heparins, the Warfarin approach, and the direct oral anticoagulant approach. Now, interestingly enough, there's never really been any randomized controlled trial which has been adequately powered to look at any of these various approaches to anticoagulation. And essentially what we're doing here is extrapolating from other clinical scenarios, such as anticoagulation in cancer patients who have thrombotic complications or who are at high risk for developing thrombotic complications. And so we're really extrapolating apples to oranges here. And essentially, this is a major data gap. And what we need to do in the future is to power studies for thrombotic outcomes rather than for other outcomes such as death, for instance. And in this regard, the easiest way to be able to approach this is by using biomarkers, because the incidence of thromboses in these diseases is so low, it would take thousands of patients in each arm in a randomized trial to really come up with any kind of statistically meaningful results. So essentially then, what the biomarker profile has been consisting of has been both laboratory biomarkers of inflammation such as P-selectin or D-dimer, or now moving into a mechanical platform using such global coagulation techniques as ROTAG and ROTEM. However, these have not been very specific, although they may be somewhat sensitive in being able to determine which individuals will be predicted to develop thrombotic complications, or for that matter, bleeding complications. So we have a lot to learn about how to apply biomarkers to the populations that we use, and it may be that we'll need a menu of biomarkers which will eventually give us some hints beyond the JAK2 allele burden and age, et cetera, and prior history of thrombosis to determine which patients would be most likely to develop thromboses, and therefore those individuals should be the ones that we should focus anticoagulation options on. Lastly, I'd like to discuss COVID-19 and myeloproliferative disorders, because when we begin to think of why there is a thrombotic predisposition in myeloproliferative neoplasms, and we begin to think of the interaction between thrombosis and underlying inflammation, COVID is probably our best disease model. And it's been clearly shown by the Italians that essential thrombocythemia, among all of the other myeloproliferative neoplasms, is most likely to be associated with an increased incidence of thrombotic complications, bleeding complications, and death. And it's very likely that the reason for these is related to the inflammasome contribution to coagulation. because COVID-19, as we know, is a highly inflammatory disease. So again, this gives us an idea, a hypothesis, perhaps, which we should be using for future clinical trials to try and understand the role of thrombosis in myeloproliferative neoplasms, and eventually to be able to provide a safe and effective strategy for anticoagulation in the patients who need it the most.